Pretty big turnout, as we expected. So my name is Rohit. I'm a BMed Sci student. I finished 4th year last year. So I'll graduate 2017. So we're going to go over some RESP today. I've tried to make this lecture a little bit less SARTAC, so I'm going to get you guys to be, talking to me and answering questions. If we had a large group, I'd put you guys into pairs, but it's pretty small, so I'll just pick on you and embarrass you in front of everyone. So I'm also Samir's brother, so he's the guy who looks like he's from Syria. And I guess we'll just start. So before we, how do I move slides? With the arrow keys. On this computer or this one? It's not on PowerPoint. I don't know how to use Macs. All right, all good? All right, cool. So, just some general advice about 3B. So when I was at your stage, I pretty much didn't know anything. But I guess just to get the most out of the year, try and be keen, get to the wards early, make yourself useful. If you're helping someone, they're more likely to help you. The more you suck up to your registrars, the more likely they'll sign random things off on your logbook without even looking at what they're signing. Study regularly and make notes. A lot of people prefer to read notes, but I think making notes is a learning exercise in itself. Do questions regularly. And I prefer the online question banks, so BMJ, Past Test, Past Medicine, whatever you can really afford. They're all about $60 or lower for about 9 months. That's all pretty decent. $100, 60 pounds. 60 pounds, yeah, but you can get a discount, 20% off. So just Google discount codes. And you're not allowed to interrupt. So practice OSCEs as well. So if you start early, I guess the goal is that you want to be able to explain every single condition on the matrix plus others between 30 and 2 minutes each. So if you can just talk about a condition for that amount of time to someone, then you're doing quite well, and you're doing much better than most people in 3rd year. And also utilize your study groups. Ask your 50 mentors to do whatever you're struggling with. So in terms of the notes, just as an example, so I used a color-coded system, and I just made it into a table, and then that worked for me. But everyone has their own style, so make sure you talk to your final years and see what works. Also, a general piece of advice would be, common things appear commonly. So in an OSCE, they're not going to put, if someone's got GI bleeding, the answer is not going to be Osler-Weber-Rendu syndrome. It's going to be colon cancer or hemorrhoids. So make sure you know the common things really well. It's good to know the random stuff with eponymous names, but it's not going to do you a lot of good in terms of the assessment. So in terms of what we'll cover today, I'm going to have a heavy weighting on chest X-rays, because I think it's something that people just don't really cover until the last minute. How many of you guys have honestly reported a chest X-ray to one of your doctors without them asking you to do that? Yeah, no one. Yeah, and that's probably what you'll be in November as well. So no one does it because A, you don't want to waste time, B, you don't really know what you're doing, and C, if you don't want to get embarrassed if you get it wrong. So we'll go over a bit of that, and we'll put that into some cases, and I'll explain the conditions after that. And then there's a bunch of slides that you can go over at home, or if we have time, we can go over here as well. So in terms of the matrix, we're covering all of those today. You can cover all of those ones at home. I've written notes, or we can cover them if we have time. And then some of the other ones are kind of obvious, or we covered elsewhere. So cor pulmonale was covered by SARTAC. Does anyone want to give me an explanation of what that is? Or I'll choose someone. I only know a few people here. Jason? Does anyone know? Sorry? Yeah, so it's right-sided heart failure, usually due to a pulmonary cause. So SARTAC would have covered that. So things like chronic lung diseases, COPD, fibrosis, cystic fibrosis, those sort of things can cause cor pulmonale. And not only that, things like sickle cell disease as well, because they can cause pulmonary hypertension. So maybe go over the SARTAC's lecture for those ones. But I'm not going to cover the other ones in much detail. So quickly, an approach to chest X-ray. So we all have our approach. Some people go from A, B, C, D, E, F, G, H, I, J, K, blah, blah, blah. But I'm just going to go through my approach. I think it's a little bit better. No bias. So this is just the normal anatomy, just for your reference. I'm not going to go over it. That would be patronizing. And here's the normal X-ray that we'll be using today. So my approach is called the IQ ABCDE approach. So my I is initial review, and that's basically all the patient details, stuff that is fairly obvious. Then Q is quality. So I'm looking for things like exposure, rotation of the film, and if the X-ray is in good inspiration as well. Then I'll look for any lines and tubes. That's kind of an optional thing. It'll be fairly obvious if they're there. And then I just go my ABCD, similar to your first aid ABCD. So it's very easy to remember. So airways. So we start by looking at the trachea. Is it midline? Is there any evidencing of stenosis or narrowing, or masses causing a pseudostenosis? Then we look at the carina. Is it normal? Is it in a normal place? Does it have a normal angle? 50 to 100 degrees is normal. Then we move on to B, which is breathing, as in the first aid. So are the lungs expanded? Are they similar in volume? So you're just comparing them. Go through your 4 zones, the apices, upper, middle, lower zones. Are the normal lateral margins? Are the lateral margins normal of the film? I don't know if that projects very well. It does. Are the costophrenic and cardiophrenic angles normal? Look for blunting of those. Are the hemidiaphragms normal? Are the cardiac borders normal? And is the lung behind the heart normal? And that's often an area that's missed. So apices and behind the heart are often areas that people don't really look at closely. Then we move on to C, which is circulation. So what's the cardiac position? What's the cardiothoracic ratio? Look at the aortic arch, look for any calcifications as well, and the hilar vessels. So these are all very straightforward things just by systematically going through from a top to bottom way. Then D is disability, so not defibrillation. So any rib fractures, look, this is where you look at the bones, see if everything's normal there. Important to look at the vertebrae as well. And then E is everything else. So just cluster everything else together. Gastric bubble, any emphysema, breast shadow is present will give you an indication if they're male, female, or just a very overweight male. And review the areas that are commonly missed. So apices, behind the heart, and below the diaphragm, especially for things like pneumoperitoneum. So anyone have any questions with, that's a pretty straightforward way of going through things and probably just revision. So what you do at the end of your OSCE is you'd compare to older films, and then you'd make a diagnosis list. And ideally, you'd like to list your diagnoses in order of probability, so the highest one first, and maybe just 2 or 3. So in an OSCE land, most of your marks will come from your methodology of how you report the X-ray. So getting the diagnosis is good. If you say this is a PE, that's fantastic. They want to hear how you said it's a PE and systematically said what's normal and what isn't normal. And that's where the majority of your marks come from. So even if you don't know what's going on, that's a little bit embarrassing for you, sure, but you'll still get most of the marks by following systematically. So other things that I guess general principles to keep in mind. So there's a few words that mean the same thing: opacity, shadowing, hyperdensity. They all mean the same thing. And then there's a descriptive toolbox, which I think you can go through in your own time, but it's just describing lesions. So another thing that's probably misunderstood is the silhouette sign, or just, I guess, how you can see 2 different structures. So if we look at this normal X-ray here, does that project? Yeah. What are these white things here? No, this is normal.
Airways.
Airways? No, common mistake. These are the vessels. These are the pulmonary vessels. So in a normal X-ray, you should be able to see the pulmonary vessels. Air, remember, is always black on X-ray. So the black parts all around this are all air. So these are vessels. This is pulmonary vasculature. You should be able to see this pulmonary vasculature all the way towards the ends of the fields on both sides. Otherwise, you're thinking things like pneumothoraces. Okay, and if we compare this to someone with a bronchopneumonia, here we have, what are these things, these black things? Anyone? Branching out? What's black on X-ray? Air. These are air bronchograms. So when people say air bronchograms, what they mean is you can see the air against the consolidation around it. And this is abnormal. And this is probably something that's not properly understood. So now you can't see the blood vessels because they have a similar interface to the pus and all the other immune gut around it. And now you can only see the air vessels because they have a different interface. Does that kind of make sense? So that's just to think about things logically. Now to move on to the silhouette sign as what it's traditionally termed. So this is a normal X-ray, and we can see the left border of the heart very clearly. Do you agree? Yep. So if we look at someone with a pneumonia, we can't see this border clearly. And here's the air bronchograms again. We can't see the border of the heart clearly because there's no more interface because it has a similar density. The heart tissue has a similar density to the consolidation around it, all the pus and stuff. So you can't really see that interface anymore. We've lost that border, but now we can see the air bronchograms. And that's something to keep in mind. Does anyone want to have a stab at what lobe of the lung that is? Left side, 2 lobes, 50-50. Okay, anyone with a upper or lower? Upper lobe, yep. Lingula of the upper lobe, yep, good. Okay, so this is the upper lobe. If it was lower lobe, you wouldn't be able to see the hemidiaphragm on the other side. We'll go through that a bit later. And then there's a DDX for, I guess, reticular patterns, which is something that you should just probably remember. There's a lot of rote learning in third year, but overall, I think it's a pretty straightforward. I don't know if Sartak went through it with you, but to get to the top quartile last year, you had to get 83 out of 100. In my year, it was 82 out of 100. So that says that the exam isn't too difficult if people are scoring highly. So I wouldn't be too worried about the written exam if you do constant study throughout the year. So in terms of case one, so I was originally going to ask you guys to pair off, but we don't have many here, so I'll just pick people. So here's the first case. I don't know, Jason, you want to pick someone? Yeah, Michael? Yeah, sure. So have a look at this X-ray. You can either give me a diagnosis and why, or you can go through it systematically. Pneumonia? Yep, sure. Why? Yep. Right middle zone? Right middle zone, yep. Yep, so let's ignore the clinical details for now because those are all dead giveaways. But what else about anything that points you to a particular lobe, you might think? Anything that's obstructed or not properly visible? What about the borders of the heart? Do you think you can see the right border of the heart properly? Yep, so that's probably a right middle lobe pneumonia. So you can go through it properly. You can just say the answer like Michael did. So this is a right middle lobe pneumonia. And again, we have the silhouette sign here. You can't really pick out the interface difference between the heart, right border of the heart, and where the consolidation starts and ends. And that's a giveaway of which lobe it is. And that's something that they expect you to know. Consolidation pneumonia are pretty stock standard cases. They're green topics. You know a lot about them. And the clinical history is very straightforward as well. So in terms of pneumonia, it's a lower respiratory tract infection. And we have two different, I guess, categorizations. We have either community-acquired or we have healthcare-acquired. So in terms of community-acquired pneumonia, we have, for historical reasons, we divide it into typical and atypical, although they have, I guess, relevance in terms of the symptomatology as well. So in terms of typical causes, we have SMH, which is strep, Moraxella, which probably don't really need to know, and Haemophilus influenzae. So those are our typical causes. And by typical, I mean they'll cause you with typical symptoms, which we'll cover in a second. And then our atypical causes are things like mycoplasma, Klebsiella, and everything else under the sun. And those won't cause your typical clinical picture that we'll go through. And I guess for a perspective on the chest X-ray, so we had a picture of bronchopneumonia earlier. Bronchopneumonia is caused by atypicals, whilst your typicals will cause your classic lobar pneumonia picture. So that's community-acquired pneumonia in a nutshell. Health, so this is your bronchopneumonia. So it's very patchy, it's all over the place. It can be most commonly bilateral, and people don't know they have it until it gets really bad. They just mistake it as a fever or, as an influenza or something. Whilst a lobar pneumonia will have a very clear area of consolidation. So in the case that Michael described, you can only really see there was obscuring of the right border of the heart, but the hemidiaphragm was completely fine. So it's very localized to one lobe. Whoops. So in terms of healthcare-acquired pneumonia, so this is just mainly a definition. You have to have been in contact for at least 48 hours, and they tend to get some of the worst bugs. So think like MRSA and all those sort of bugs. People underwent, I guess, intubation, mechanical intubation and ventilation, or people who had strokes and things like that are at a higher risk. So in terms of pathophysiology, there's usually some sort of aspiration. Whether that be they just inhaled something or they physically aspirated, like if someone had a stroke and they had some sort of bulbar palsy and they aspirated something like that. And then there's an immune reaction and basically get a buildup of immune guck, neutrophils and other inflammatory cells, and that just causes the consolidation that you can see in the picture here. And I think you guys have a lot of pathology in third year, which something is not, so that's something that I didn't have. But in terms of looking at pneumonia macroscopically, this is not something that you want to be doing regularly because these patients should be living and not be having their lungs taken out. But basically you have early and late stages. So early stages is the lungs turn a little bit red, and it's something we call hepatization, kind of looks like a liver. And in late stages, like this upper lobe here, we have, I guess, the lung appears more gray. And that's just a sign of there's a bit of fibrosis and fibrin going on. So the clinical symptoms of pneumonia. So the typical symptoms you'll have are fever, rigors, which is like shaking when it's not even cold, a productive cough. It's worth asking about productive cough, but it's not heavily reliable. A lot of people will just normally have green sputum just because they might have a little bit of a viral thing here or there. So it's not a terribly reliable symptom. And then they have other things like chest pain, shortness of breath, depending on how bad it is. In terms of clinical signs, crackles, hopefully you've all heard crackles before, increased vocal resonance and dull percussion. And it's important in Monash exams to distinguish between dull percussion and stony dull percussion. Stony dull percussion is, pleural effusions, and you can't really hear the difference clinically, but that's just a Monash differentiation. So in terms of atypical versus typical, typicals will have those symptoms. They'll have all of those things we just said, and atypicals will have all the weird things. They might present more like a viral illness. They'll have headaches. They might have diarrhea. They might have aches and pains and myalgias and stuff. So this is just a summary for your own information, just on the clinical findings of various conditions. So there's all these buzzwords, unfortunately, with pneumonia. So not only do they want you to, I guess, see that it's a pneumonia, but they want you to figure out what type of pathogen it is. And I'm not going to read these to you because that will just take too long. But some of the more important ones, I think, are, so psittacosis is bird handlers. Coxiella burnetii or Q fever will be people working with cows or working in abattoirs. Klebsiella, people who are alcoholics and will have the red currant jelly sputum, which is different to red currant jelly poo of intussusception, although they probably don't know the difference because they're alcoholics. Legionella, they'll be coming from a hotel or something like a shitty hotel that has air conditioning problems that hasn't been looked for in a while. Mycoplasma is the classic atypical presentation, the most common atypical that'll have headaches. And they can also get hemolytic anemia, but that's probably something that you'll cover later. PCP is in AIDS patients or HIV patients. And Staphylococcus, typically they'll be recovering from a viral illness. So because we're living in a Donald Trump era, I guess we've got to think about, anthrax and other shit that could go on in the next few years. So keep that in mind and probably post that on your wall somewhere. So in terms of pneumonia, it can complicate as various things. So abscess, pleural effusion, empyema. But I guess how we measure the severity is through the Curb 65 score. And this is probably something that I'd probably try and commit to memory. And I'm not going to go through it because it's just listed here, but it's something that you need to try and remember or at least name drop as something that you'd utilize in an OSCE for measuring their severity. Investigations, so pretty straightforward. Obviously, you want to be, with all of these, you want to be ruling out other causes of, say, like chest pain or dyspnea. But the specific investigation that'll help you would be sputum, MCS, urinary antigens, which help for Legionella and strep pneumoniae, a chest X-ray, which can be normal or cannot be normal, and you're looking for air bronchograms and the silhouette sign. So these are our 4 silhouette signs. This is the one from the question. This is the one where we already talked about before. This one we have some obscuring of the hemidiaphragm here and the hemidiaphragm on the other side, and that gives you 4 out of the 5 lobes. So atypicals, as I mentioned, bronchopneumonia, so very patchy all over the place. You'll still have the air bronchograms, but it'll be fairly obvious that it's a different sort of presentation. Management, so this is something, again, you need to commit to memory. It's a lot to take in, but rote learn it, try and remember it somehow. So in terms of mild pneumonia, amoxicillin is the first line, but if you suspect an atypical such as mycoplasma, then you might jump to doxycycline. And after that, I mean, ETG has a few, but I'll just remember I usually just remember the red ones. So benpen and doxy for moderate stages, and severe azithro and ceftriaxone. And for health-acquired pneumonia, I probably wouldn't remember it because it's probably unlikely to come up in an OSCE. So make sure you commit these to memory, and these are from ETG. So lung abscess was one of those complications, and it does have a few buzzwords, but the classic people who get a lung aspiration are the classic people who get a lung abscess, the people who are more likely to have a lung aspiration. So people who would be more likely to have that would be alcoholics because they don't know what they're doing, people with strokes or Parkinson's disease or multiple sclerosis who have a predilection for aspiration because of neuromuscular problems. They're more likely to get abscesses because they're going to have a lot of things aspirated compared to someone who just gets strep pneumonia because they just inhaled something. And the clinical features are classically a swinging fever, so it gets better, it gets worse, gets better, it gets worse, but it doesn't, fully get better. Foul smelling, brown sputum is a very classic Monash buzzword. They might have hemoptysis as well. In the investigations, it'll be fairly obvious on chest X-ray. You'll have this lesion with an air fluid level. So horizontal lines in the body just don't exist. So any horizontal line you see, perfectly horizontal line in the body, that's always abnormal and worth looking at. The body doesn't make horizontal lines. So this is a perfectly horizontal line, and that's the air fluid level there. And management, you use some pretty severe antibiotics. So tazocin is pretty bad, and surgery, you can debride the abscess as well. So any questions on that so far? No? Okay. Michael, do you want to pick someone? Yeah, so tell us what do you think about this chest X-ray? You can go through it systematically, or you can just tell me the answer. Sure.
Okay, so starting obvious defect is the opacity in the left upper lobe, I think.
Yep.
And given this history of 5 kg unintentional weight loss for the last month and recent hemoptysis, I would think that it's a cancer or something.
Yeah, lung cancer, definitely. So this is a huge mass. Usually people might be thinking, do I call it a mass? Do I call it a nodule? This is really big. This is nearly as big as part of the heart. This is definitely a lung cancer. So when we're talking about lung cancers, most of the lung cancers we can describe either histologically as in what the cells are or the location. The location is not very useful because 95% of them are near the bronchi. They're bronchogenic lung cancers. So histological is probably the more useful thing. But it's important to realize that masses in the lungs are more likely to be not lung cancers. They're more likely to be colorectal cancers or renal cell carcinomas or something else. But usually they will have multiple masses. When there's usually one big lesion, it's more likely to be lung cancer. So the major risk factors for lung cancer are smoking, and smoking. So smoking is the biggest risk factor for lung cancer by far. But not everyone who smokes will get lung cancer. There are success stories of people who drink a bottle of wine a day and a pack of cigarettes a day and they'll live to 100. But that's probably being a little bit risky. So smoking is the biggest risk factor, and a 40-year pack history multiplies your risk by 20, which is pretty big. Asbestos is another big risk factor, but that's usually more associated with mesothelioma in Monash exams. And there are a few genetic risk factors as well. So the clinical features of lung cancer, just like any cancer, weight loss, unexplained weight loss, a cough, dyspnea. You could get a wheeze, and the wheeze will be monophonic. And does anyone know why it'll be monophonic? No? So it'll be monophonic because most lung cancers are in the bronchi, right? They're bronchogenic. So they'll be causing a regular, a pseudostenosis of the bronchus. And that'll cause turbulence only, the turbulence can only be of one pitch, and that's monophonic. So it'll be a monophonic wheeze. And we compare that to a polyphonic wheeze of asthma, where there's so much variation. Wherever you hear on the chest, you'll have a different, musical tone to the wheeze. You can have superior vena cava syndrome, which is where the mass impedes on the SVC, and that can cause a whole range of issues. And then we can have metastases, so bones, adrenal glands, brain, liver, etc. So how we divide lung cancers, they're either small cell or they're not small cell. So adenocarcinomas, which are a non-small cell, are the most common. So small cell are really bad. So most small cell lung cancers are already metastasized upon presentation. The patients have very little time to live. Chemotherapy is the best treatment for these people, but it's still really bad, and most of them die, unfortunately. But this one, in terms of Monash exams, is really important because it has a lot of paraneoplastic syndromes, and these are ones you have to know. So it commonly causes Cushing's disease through ectopic ACTH. So that's probably something that you would have looked at last year in your endo lectures. It can cause SIADH, which is that euvolemic hyponatremia that you can get with ectopic ADH production. Lambert-Eaton myasthenic syndrome, does anyone know what that is? So have you guys heard of myasthenia gravis? Yep, so people will get weaker as they, fatigable muscle use. Does that ring a bell to people? Lambert-Eaton syndrome is the opposite. So as they do more exercise, they'll actually get stronger, which is very weird. And those are probably your main paraneoplastic syndromes that are commonly associated in questions with lung cancer. So this is your small cell cancer. It's all over the place. It looks ugly. Adenocarcinoma is the most common cancer and the most common non-small cell lung cancer. It's the most common in smokers, and also it's the most common in non-smokers, but still the most common overall. It's usually peripheral, but still around the bronchi. The paraneoplastic syndrome that you need to be aware of is HPOA, so something that you all would have looked for in your RESP exams last year by testing wrist tenderness. So just on a note with that, HPOA only occurs with clubbing. So if there's no clubbing, you look like an idiot looking for wrist tenderness, because even if it's there, it's not HPOA, it's something completely else. So make sure you have some clinical correlations of why you're actually doing things in the exam. Squamous cell lung cancer, second most common, 25%. And the paraneoplastic syndrome that you need to be aware of is hypercalcemia. And then large cell cancers are just kind of a mixed bag of either adeno or squamous, so people can't tell which one is which, but they tend to be bad in prognosis. More pictures that you can go over at home. So in terms of the investigation, screening is not really recommended, but the most common investigation people get done is a chest X-ray that'll show a lesion. And I think nodules and masses are on your matrix. So the difference between a nodule and a mass are, it's a matter of size. So 3 centimeters or less nodule, more than 3 centimeters in size, then we're looking at masses, and masses are more likely to be malignant. So there's a mass there. And here we have a mass in the apex. So always make sure you look in all those review areas. And this is, if we compare this to this X-ray, which has masses everywhere you look, these are cannonball mets, and this is from metastasis. So multiple lesions, they look like cannonballs. That's something that you need to differentiate. So the other investigation that's more helpful, I guess, is a CT. CT or a PET scan using glucose. And that'll give you, I guess, a better indication of the staging. Because if it's lung cancer, it'll light up like a Christmas tree on a PET scan. So very useful. There's T&M staging for everything except for small cell, but I don't think you need to know that. It's probably overkill, but it's there for your reference. The other investigation that people would do is a bronchoscope. So they'd actually find a bit of the lesion and get a biopsy, and that's obviously something that's very useful as well. In terms of management, just with every cancer, if you name drop chemotherapy, radiotherapy, and surgery, you're probably not going to be too far off from the truth. So just go with that. Mesothelioma is a bit of a strange one. It's the one that's associated most with asbestos exposure. So I guess if you guys did that thing in second year where a group would have talked about asbestos for, I don't know, too long, you should know a bit about it. So making sure that, I guess the occupations at risk in Monash exams always insulators, because that's where, James Hardy did their best work. Mechanics with brake pads. The brake pads used asbestos, and that's another common association. And it's always important to talk about legal advice, because these guys really screwed a lot of people over. And that's something, if you mention an OSCE, people will think you're thinking very holistically and that you know a lot about medicine, which is the goal. So the obvious, I guess, finding on CT scan would be thickening of the pleura. If you see this, this is really going to be, nothing else. This is definitely mesothelioma with a history of asbestos exposure. Also, something about asbestos exposure, unlike pleural plaques or unlike asbestosis, which is like a occupational lung disease of asbestos, you only need to have a little bit of asbestos exposure to develop mesothelioma. And the latency period, and this may or may not have been relevant on an exam that I sat once, is about 30 to 40 years. So this is a really long latency period for cancer. And once it starts happening, it's really hard to stop. The only way to really stop it is do a pleurectomy, take out the bit of the pleura, and that's still not very good. So did you do the last X-ray? You want to choose someone? Choose a girl. We haven't had a girl. Right. This one's pretty straightforward. Don't help her, Jason. Well, what's the answer then? Pleural effusion, why do you say that? So I wouldn't call this consolidation. So consolidation is more a descriptive term of pneumonia. I probably call this wide out of the lung until the mid zone on the left side. Just because you can't see any air bronchograms, right? Air bronchograms are defining consolidation. In pleural effusion, you don't see any air bronchograms because the fluid is actually compressing the airways, so you're not actually getting any air there at all. So you wouldn't see the air bronchograms. So this is definitely a pleural effusion. And I guess the giveaway sign is it's all white. You can't see the diaphragm at all. There's no borders visible, which is, I guess, silhouette signy. But you also have this meniscal sign where it rises, the fluid rises a little bit towards the end of the chest cavity on either side. So the definition of pleural effusion is obvious, so fluid in the pleural cavity. And there are two types of etiologies that you need to know. So it can either be transudative or exudative. So transudative, if you don't want to think about it like very deeply, just think transudative is all the failures. Heart failure, kidney failure, so chronic kidney disease, thyroid failure, hypothyroidism, liver failure, which is cirrhosis. All of these things will cause a transudative pleural effusion. And that's because you're lacking albumin and other proteins, which causes the fluid to move outside of the vessels and into basically third spacing the fluid. Then you have exudative causes, which are local diseases. So in terms of the lungs, things that could cause would be infection of the lungs, so pneumonia, an infarct of the lungs, like a pulmonary embolism, a malignancy, so a lung cancer or a mesothelioma, and other things like that. So local diseases versus systemic diseases, so local versus failures. And this is the pathophys. So as I mentioned, with the transudative cause, you have a lack of protein, so the fluid leaves the vessels. And an exudative cause, you actually have damage to the vessels themselves, so the fluid can leak out through the endothelium. So the clinical symptoms and signs, you'll have dyspnea, just like everything else in this lecture. Dyspnea is a common symptom, and pleuric chest pain. You can have that. Signs are the most important ones. So you can have tracheal deviation, especially if it's a big effusion. It can deviate away from where the effusion is. You'll have changes in vocal resonance. So unlike consolidation, which had an increased vocal resonance, pleural effusions have a decreased vocal resonance. And if you've ever done physics, if you put your stethoscope on a table and you tap it, you'll hear it much louder than you'll hear it much louder because sound transmits louder in solids, which is basically what consolidation is. But a pleural effusion is water, which is why when you're in a swimming pool and someone says something to you, you can't hear anything what they're saying. So that's just a basic conceptual understanding. So the pleural effusion have decreased vocal resonance, and decreased vocal resonance means when someone says 99, it'll sound more, I guess, it'll just sound less clear than it usually does. And then you'll have that stony dull percussion, which is very classic but not possible to actually do in real life. So Light's criteria is the thing that you want to be doing, and that you get that from a pleural tap. And you probably need to know Light's criteria by name, probably not the specifics. And that'll differentiate between a transudative and exudative cause, if it isn't already obvious by if they have cirrhosis or not. And then there's clues in the fluid analysis. So a low pH can sometimes on Monash exams mean empyema. If there's a lymphocytosis, think infections such as TB. If there's amylase, think esophageal rupture. If there's low glucose, think of malignancies or other sorts of infections, such as bacterial infections, similar to low glucose on CSF. The investigation, so CXR, we've already looked at. You get a blunting of the costophrenic angles and the cardiophrenic angles with a meniscal sign. You get this whiteout of the lung. So no air bronchograms. This is a different pathology. The airways are squished and there's no air to actually make air bronchograms. So further investigations, I guess this is probably too much to know, but there are ways of differentiating it from non-fluid effusions as well, so keep that in mind. And the management is, I guess the acute management is a thoracentesis, which is diagnostic and therapeutic. So diagnostic for Light's criteria and further analysis, and therapeutic to drain the fluid. And then you treat the underlying cause. If it's recurrent, you can do a pleurodesis. Does anyone know what a pleurodesis is? Anyone? You do?
Can you surgically connect the two layers of the pleura?
You can. So usually that's not the most common one. So the most common way you do it is a chemical pleurodesis. So what they do is they give you an agent in between the two layers of the pleura, and that causes fibrosis of the two pleural layers. And talc is the most common thing used. It's a magnesium compound, and it basically causes fibrosis. So there's no way that there can be an accumulation of fluid in the pleural space. But yeah, surgical pleurodesis is also possible. Do you want to choose someone? Yeah. So this isn't a chest X-ray, but I guess you guys are experts on ECGs after Sartak's lecture. So for this one, you might want to just run through it systematically, just out loud. Yeah.
There is there's axis deviation.
Yeah, there is. With left, right, normal.
I think it is right.
Right, I agree. Good.
The rhythm is
80. Yep, good.
The rate is regular.
Yep, good.
There are P waves.
Good.
The PR interval is normal.
Yep, good.
The QRS is in lead 2 is not. I don't know how to describe that. It's not like a big one.
This here.
Yeah.
Yep, don't worry about that one.
Alright.
Tell me more about these ones.
The other ones.
Does it give you a? Does it look like an M or a
Yeah,
something?
It looks like an M.
Yeah.
And it's like W and V6.
Yeah. So what type of what does that suggest to you?
I think that is right on the benchmark.
Yep, good. And ST, T are normal. Yep.
Yeah.
So one more thing I'd like to add, but you're not going to get it unless you specifically know you're looking for this, is a pattern called S1Q3T3, which I think you have to really know to pick that out. But you have very deep S waves in lead 1. You have deep Q waves. So usually you can barely see the Q wave unless it's a previous infarct. These are very deep Q waves in lead 3 and inverted T waves in lead 3. That's called S1Q3T3, and that is on every Monash exam ever. And it's a very classic sign, but it's also very rare. Does anyone know another condition where you'd get really big Q waves? Dagger Q waves. Sartak went over it, I think. I wasn't listening. I'm sure he did. Nope. So Hockham. So if you guys remember hypertrophic obstructive cardiomyopathy, the Q wave is caused by septal depolarization. In Hockham, you have a really, really big septum that causes the problem with you get the murmur from the septal hypertrophy, and that causes very deep QA because there's more septum to depolarize. No, you can't ask questions.
You said that S1Q3T3 is really rare. Is that rare for PEs, or that catching a PE on an ECG is rare?
No, it's very rare in general.
So will all PEs have it?
No, it's very rare.
I have the understanding that sinus tachycardia is the main features of PE.
It is.
Is the reason why this is not tachycardia due to the right branch block?
Yeah, the right bundle branch block usually doesn't come with tachycardia, but I guess it's just it's a very variable presentation. So ECG isn't the thing you want to be using to diagnose a PE. But yeah, you're right. The most common features of a PE would be, a sinus tachycardia, right axis deviation or extreme axis deviation, right bundle branch block, and then you're looking at things like S1Q3T3. So this patient has 3 of those 4. So it's still suggestive of a PE. But yeah, sinus tachycardia is very common as well. But if this happened in a really fit person, you might not expect them to get sinus tachy because they've already got such a low borderline heart rate. Does that kind of make sense? And I don't know who this patient was. So in terms of the PE itself, so remember Virchow's triad that some guy would have talked to you about last year, stasis, endothelial injury, and hypercoagulation. So the main thing in stasis of venous flow is immobilization, so post-surgical patients, post-ortho patients, or like a really obese person on an airplane, something like that. Hypercoagulation, the main thing you want to be thinking of is cancer. So all malignancies inherently cause hypercoagulation. So that's why they all predispose to having PEs. Other things you want to think of are pregnancy, or if you're on the OCP. Those are predisposing factors as well. Another thing I wanted to mention is not always is the embolus of vascular origin. So post-ortho surgery, especially long bones that have a lot of yellow bone marrow, you can get fat embolization as well. So keep that in mind. And Virchow didn't actually describe the triad, so it's just named after him. So I thought I mentioned that for historical purposes. But anyway, on pathology, there's a very characteristic look to pulmonary embolisms, and that's you get a triangle, and you get this wedge-shaped infarct here. And the reason for that is you have one big vessel that got occluded, and then all the vessels that branch from it get no supply. So you get a triangle of infarct. Does that kind of make sense? And that really applies to every single type of infarct anywhere in the body, except maybe the myocardium. Everything has a sort of triangle-shaped infarct. So risks, I've already gone through a lot of these, but also think of your heme conditions. So antiphospholipid syndrome, factor V Leiden, protein C, S deficiencies, which are all extremely rare. And then there's a few other things. SLE, apparently people with non-O blood type have a slightly higher risk, probably not something to worry about. And the clinical features are unexplained dyspnea, hemoptysis can happen, pleuritic chest pain can happen, but usually it's very acute dyspnea, unexpected dyspnea, with a previous history, maybe a swollen leg or something. That's a very characteristic picture. On Monash exams, they also like to have a sudden urge to defecate. which is very odd. And I looked it up because I'd like to do that. And we came up with this article from 1991, and basically it just proves that it's untrue. And what happens is that they defecate and then they get the PE, rather than they get the PE and then feel like they need to have a shit. So Monash exams are just read it the wrong way around. But anyway, that's just a point of note. When you're dealing with PEs, there's a few criteria that you can use. And again, I think I just remember the names, not the criteria, because they're quite long-winded. So the modified Wells criteria is modified from the Wells criteria of DVTs. And that's something that you can name drop and just use. And there's also a PERC criteria, and this is from a Moodle quiz, a radiology Moodle quiz done by the College of Radiologists. So in terms of the Xray, the ECG what you talked about, the Xray has a number of features that aren't very reliable. So most Xrays in PE are completely normal, but there are a few features. So you can get this wedge-shaped infarct again, which is called a Hampton hump. You can get a Westermarck sign, which I don't really know what that means. These are big words that I don't know what they mean. You can get Fleischner's sign as well, which you just get, I guess, enlarging of the vessels and the pleural effusion. And you'll have to forgive me for this, but I always wanted to do this. But Illuminati confirmed on the PE X-ray. So in other investigations, the main investigation we're going to be doing is a CTPA. And you got to understand that CTPA doesn't stand for CT, it stands for CT pulmonary angiogram. And I mention that because we may or may not have had an exam where the answer was pulmonary angiogram and everybody picked CT because they thought CTPA, the PA didn't know what they meant, but they know what CT means, so they picked CT. And that was a very easy question to get right. So CT pulmonary angiogram is investigation of choice. The only reasons why you wouldn't give it is if they can't handle the contrast, or they can't fit in the machine because they're an elephant or something. And yeah, anyway, that's important because I had a 10-week bariatric rotation at Eastern Health where they teach me a lot of good in exam-related stuff, and we had a lot of problems with getting patents and CT scans. Anyway, VQ scan is the second best, and VQ scan you do when there's contraindications to CTPA. So always CTPA first, and when they can't handle the contrast, or they're pregnant, or they're too big for the machine, then consider a VQ scan. So management, and these are things that, again, you really have to know and rote learn these. You give them oxygen, you give them analgesia, just like you give anyone with pain. It's always something you can say. And then IV unfractionated heparin is the thing you want to be giving them. And then you consider your long-term anticoagulation therapy with warfarin. And it depends on whether it's provoked or unprovoked, and if it's the first one or if it's a recurrent one, depending on how long you give the anticoagulation for. I'm not going to read this out to you. You can just read that yourself at home, but you need to know these. So case 5, do you want to choose someone? Yep. TB, why? Not from the clinical history. Because everyone knows that Indians have TB. Yes? Yes? Yep, so there's definitely some opacity, consolidation, some sort of hyperdensity there. I agree. Anything else that you think's wrong with it? Hyperinflated? Not really, not so much. Hyperinflation, a good way to look at it is look at the hemidiaphragms. If they're nice and curved, it's probably not hyperinflated. If they're flat, like in COPD, then they're hyperinflated. So the other thing to note here is that the hyla are very pronounced. So the hyla goes on for ages here and ages for here. And that's a feature that you probably should recognize with TB. But only, again, that's something that you'd only look for if you knew about it beforehand. But it's really good that you picked up this subtle apical consolidation appearance. That's very good. So TB, caused by Mycobacterium tuberculosis, which is different from Mycoplasma. So a lot of people in my year chose Mycoplasma tuberculosis as an answer that for an exam that we may or may not have had. So keep that one in mind. And in the lungs, and this is important to differentiate from a condition called sarcoidosis. In TB, the granulomas that you get are caseating granulomas. So they have this central cheese-like necrosis. The risk factors, Indians, anyone from Asia, anyone who's recently traveled to an Asian country or an endemic country, Aboriginals, because unfortunately they have a higher rate of TB, social workers who may deal with Aboriginals or people who are more predisposed to having TB, immunocompressed people who haven't had the vaccine, which isn't a great reliable marker because most of us, probably none of us have had the vaccine. And of note, it's also a notifiable disease, so keep that one in mind. So these are the areas where you'd suspect TB. So a lot of these African countries, but people tend to visit more Asian countries than from Australia. So hence Asia is more like a predisposing factor, which doesn't speak for our Indigenous population because we actually have a higher, if we were looking at Indigenous population, we'd probably have a color more like this. But I guess the Monash buzzword is your Indians. And this is a gif of my brother dancing at home without shoes that I thought was relevant for an Indian. So I suggest you look in his profile and download that and post it everywhere. I think it's fantastic. In terms of TB, the classical signs and features. So we have fever, we have night sweats, and we have weight loss. So those aren't highly specific types of things. And signs, we might not get any signs. So we're just looking at symptoms. Then there's specific types of TB. So we have pulmonary TB or post-pulmonary TB. And that's the classic TB that we're talking about, where it's just affecting the lungs. So we're looking at that chest X-ray, we're having the similar things. So our symptoms would be lung symptoms, coughing, chest pain. They might have a little bit of hemoptysis. They can get that upper lobe fibrosis that our colleague just described very nicely. And that's usually in post-pulmonary TB. So the actual primary infection itself is more often than not asymptomatic, but it's only once it's, I guess, reactivated from a latent phase that it starts to become symptomatic. But you also have different types of TB. So you have an extrapulmonary TB, which, as the name suggests, is TB that affects other parts as well as the lung. And you can get a whole bunch of things. Important things, I think, are osteomyelitis, which is called Pott's disease. Again, may or may not have been on an exam. And that's specifically in the spine. And sterile pyuria as well, which is a bit of a buzzword. And I'm not entirely sure how that happens. And then you have miliary TB, which is spread of TB through the blood system and through the vessels. And that causes a whole lot of problems as well. But I guess the main finding of miliary TB is what the X-ray looks like, which I'll show you in a minute. So the key investigation is to use a Zeal-Nielsen stain. And that is a massive buzzword. And if they don't mention Indians, they'll mention a Zeal-Nielsen stain showing acid-fast bacilli. And that's basically what it looks like, and it's very obvious. That's nothing else uses a Zeal-Nielsen stain on Monash exams. Latent TB, if you want to diagnose that, that's when you look at your MAN2 test, which is that subcut test you all might have had in first year, or if you had a quantiferon gold test as well, if you're a little bit more rich. In terms of the CXR, as mentioned, fibrosis, you might see a lesion, you might not see a lesion. On the one that our colleague described, there was no lesion, but this one has a lesion. And they have this bihilar enlargement, and that's really important. There's two things that can mainly cause that on Monash exams, TB and sarcoidosis. And then there's other things such as cancers, breast cancers, lung cancers. So miliary TB is disseminated. It is everywhere. And this is a very characteristic pattern of miliary TB. And it looks a little bit like bronchogenic pneumonia, but the history will be a little bit different. They'll have hemoptysis and more significant weight loss, and they'll have a travel history. It'll be fairly obvious to differentiate the two. The management of TB, you really need to know. This is from ETG again, and you need to know the specific time durations for these therapies as well. So first of all, you want to isolate the patient if they've got active TB, keep them in one of those special rooms in the wards where you need 2 sets of doors to go in. And then your therapy is ripe. So rifampicin, you give for 6 months. Isoniazid, you give with vitamin B6. Or pyridoxine, because it can cause a neuropathy if you don't give that. So you give that for 6 months, and then you give the other 2 for 2 months only. So pyrazinamide and ethambutol. That should be bolded as well. So you give all of those, you start them all at the same time, but the first 2 go on for an additional 4 months. And you also need to know the side effects. So rifampicin causes your orange urine and orange bodily secretions. Isoniazid causes that peripheral neuropathy, which you prevent with the vitamin B6. Pyrazinamide causes gout, and ethambutol can cause optic neuritis, which hopefully Nathaniel will cover in a future talk. And that's probably not so important. So make sure you put those therapies, to really put them into memory, because you need to know those. So sarcoidosis is another differential for bihilar enlargement. It does come up in exams occasionally, and these are non-caseating granulomas, and it's some autoimmune condition, I guess it's thought to be. And you get this bihilar enlargement, and there's a 1, 2, 3 sign, which includes the hilum, both hilar on either side, and also paratracheal lymph nodes. But bihilar enlargement is the main thing. And as sarcoidosis progresses, it becomes fibrotic. And you have, I guess, this sort of pattern, but all over the lungs. That's obviously quite bad. This is probably a stage 1 or stage 2 sarcoid. The clinical features are very variable, and it's multi-organ, so I'm not going to go through it, but the main ones you need to know are erythema nodosum, which is these painful bumps on the shins. They can be red. lupus pernio, which is a rash on the nose, and that's probably it. So this is lupus pernio. This is a syndrome with enlarged parotid glands where they kind of look like a raccoon with uveitis, and this is a really cool, I guess, the bone changes you can get as well. So the main investigation, so in terms of sarcoid buzzwords, we have an autoimmune non-caseating granulomas with bihilar enlargements with respiratory symptoms plus erythema nodosum plus lupus pernio, and the last thing is increased ACE. And that is pretty much your presentation for sarcoidosis on an exam. So you want to pick someone? Yep. Cool. Yep. Pneumothorax, definitely. Which side is the pneumothorax on? Left side? Yeah, I agree. So this is a very classic picture of a pneumothorax, but you should be looking at the X-ray. Whoops. You should be looking more at the X-ray. So you can't see the lung markings. And remember, by lung markings, we meant pulmonary vasculature. That's the white stuff. You can't see the white stuff anywhere over here. The lungs kind of ended there. And, you know, this is all very blank, just air. So pneumothorax, air in the pleural space. I'm not going to, you know, harp on about that. There's different types of pneumothoraces. You have spontaneous primary and spontaneous secondary, and you have traumatic ones. So spontaneous primary are like the question, a tall person just gets them, or they might have a problem with connective tissue disorders. So they might have Marfan syndrome, which is a fibrillin problem, or Ehlers-Danlos syndrome, which is the one where they can bend their body parts in extreme degrees. Homocystinuria also has a connective tissue aspect to it. Spontaneous secondary pneumothoraces are probably the most common though, because COPD is so common in our society that if a bullae ruptures, so a bullae is just a collection of air because all the alveoli have been destroyed. If that ruptures, then it's going to cause a vacuum and it just pulls the lung off the visceral pleura and you get a pneumothorax. And the classification is simple or tension, and tension is the bad one. So signs and symptoms, chest pain, very vague, dyspnea, very vague, they don't tell you much. What tells you a lot is the hyperresonance to percussion, because you're percussing air. You're basically percussing like a barrel full of air. And the features get progressively worse in a tension pneumothorax. So in a tension pneumothorax, you have that one-way valve where the air's just coming in, but none of the air's going out. So the mediastinum continues to shift to one side. We get massive tracheal deviation, and that compromises your cardiac function and your respiratory function. So here's a pneumothorax with arrows pointing to where the lung markings end. Very straightforward. That's in an ICU. You can read that in your own time. And this is a tension pneumothorax where we're getting a little bit of mediastinal shift from a pneumothorax on this side. So the management is actually very complicated. I've just really dumbed it down to the very basics. There's actually very complicated algorithms that people use in ICUs and things to actually manage a pneumothorax, and there's a lot of maths involved. But very simply, you give them oxygen and analgesia, and they usually get better. If it's very large, then you can stick a needle in and drain the pneumothorax. And there's a lot of conjecture into exactly where you put that needle, and different sources will say different things. So hopefully they won't ask you that, because it's a bit of a problem. And if it's recurrent, which could happen with someone with Marfan syndrome or something, then you can do a pleurodesis as well. So an approach to pulmonary function test. So we've done enough about X-rays. So I'll just talk about the other important investigation that is very OSCEable, and it did come up in my OSCE where we had to interpret LFTs. So this is just for your reference. You should know these basically. And the one of importance is the vital capacity. Is that coming through? No, the vital capacity VC. So PFT is a bit of terminology. So FEV1, forced expiratory volume in 1 second. FEC, how much you can fully expire with maximal, I guess, maximal effort. The ratio of the two, and then the DLCO, which is using carbon monoxide, which is a special test. So how you'd be doing PFTs, you'd be, first of all, the first things to look for are at the FEV1 and the FEC, then look at the ratio, and hopefully by then you'll have discerned whether it's obstructive or restrictive or maybe a mixed pattern, and then look at previous PFTs or ask for them, and if it's not clear, then look at the DLCO as well. So just obviously, this is an obstructive pattern. We get this I guess, very concave slope, convex slope here. And this is a restrictive pattern. So the ratio is the same, but it's just everything's just decreased. And these are things that should be recognizable to you from last year. So common procedural errors, I'm not going to go over them, but they're fairly obvious. And DLCO interpretation, it's really mainly only used in restrictive lung conditions. So the DLCO will be lower in restrictive lung conditions. And that's probably, if you just take that point away from the slide, I think you've done well. So case 7, you want to choose someone? Choose a girl. Do you know any girls?
No.
Did you choose someone?
Yeah.
Yep, cool. There's a couple more where that came from. COPD? Are you just getting that from the words, or because someone smokes they have COPD?
And there's not many changes from COPD.
Yeah, no, not really any changes post bronchodilator, I agree.
Yeah.
Well, what else do you think about the PFT? So the predicted percentages are FEC is 100% of predicted, and normal is above about 80 or 75. FEV1 predicted is 95%, and the ratio is 73%, which is above 70, which is normal. Does that ring any bells? So 3 things were normal. It's either abnormal or normal. Yeah, so this is a normal PFT. So make sure that this is something that happens in OSCEs, and we may or may not have had a normal PFT, and people said it was all sorts of random conditions. Some guy said it was cystic fibrosis. These things don't happen. So make sure you look at it, take your time, and if you go through the list and FEV1 is normal, FEC is normal, the ratio is normal, it's normal. So keep that one in mind. You want to pick someone? Sorry, I tricked you, but that's fine. I have no regrets. Yep. So this is another PFT. This one's not normal.
Okay, I'm just looking at the graph because I think that's a very easy way of interpreting.
Sure.
Looking at the actual peak flow is lower, but the volume is normal, so I'll be thinking about an obstructive disease.
Definitely.
Cause. And looking at the 20-year-old woman and looking at the post-PD change, there's a market change there because it's above 15%.
Yep.
So I would say this is asthma, and looking at the clinical vignette, it seems to suggest asthma as well.
Yep. Do you know you mentioned 15%. Do you know any other criteria for asthma? A milliliter change? How many mils? 200, and this is increased by 200 or more? 0.25 liters, which is 250, yeah? So it does. So that was really good. That would get you full marks for definitely interpreting this. So this is definitely obstructive picture with post-bronchodilator change. This is asthma. And asthma is a chronic inflammatory condition. And basically you have a few things. You have a biphasic pathophysiology. So you have bronchoconstriction, and then you have inflammation. And this inflammation leads to chronic airway remodeling. Can anyone tell me why chronic airway remodeling is a bad thing for asthma? What does it mean clinically for them?
COPD.
It can lead to COPD in a definitional sense, but anything else? It means that you can get, it means that the bronchodilators can stop working. So you can actually get, like with antibiotics, you can become resistant to your bronchodilators, and you'll have progressively need worse and worse therapy if your asthma is poorly controlled. So once you've got fibrosis and airway remodeling in your lungs, then you're going to need a lot stronger medications to get yourself back to normal. So in terms of asthma triggers, you should probably know a few just to name drop them. Infections are very common: cold air, exercising, pollen, animal fur, and occupational asthma, which we'll cover in a second. So the clinical symptoms are typically worse at night. And sometimes all they'll give you is a night cough, a nocturnal cough, as the presenting symptom. And because it's nocturnal, think asthma. And nocturnal, I think it's because it's just generally colder in the night, although I'm not entirely sure. So they have acute dyspnea. Usually there's a trigger. It should be fairly obvious. Increased work of breathing. You'll hear this polyphonic wheeze on auscultation, although that's not entirely reliable, because in really, really bad asthma, you can get a silent chest and no wheeze at all. So make sure you're looking at the patient and seeing what they have first. So this is just the difference between stridor and wheeze, and there's some, I don't think they'll work here, but basically stridor is an upper airway obstruction, and when you get to the bronchi and the trachea, you have this so-called expiratory stridor, which most people would tend to call a monophonic wheeze. And then once you get below into the bronchioles, etc., into asthma territory, you get a polyphonic wheeze. So stridor is inspiratory, upper respiratory tract. Monophonic wheeze is more middle, and then lower you get a polyphonic wheeze. And then severity, I think the most important thing to look at severity is how they can talk to you. Because I think that's a very easy way of seeing how bad they're going. If they can talk pretty normally, then their asthma is not too bad. But if they can barely talk to you, then that's an indication that their asthma is, you know, quite severe or nearing critical stages. And then there's all these patterns of asthma that I don't think you need to know too much, because asthma is such a really big pediatric condition in 4th year. But basically, you have different patterns of chronic asthma, and just leave it as that. So we've already talked about some of the investigation findings. So decreased FEV1, decreased ratio, and response to bronchodilators with an FEV1 change of over 12% or over 200 milliliters. And then you can do other testing as well if the results are unequivocal. And also consider allergy testing, because a lot of these patients have an atopic tendency as well. So make sure that you're testing for allergens in case it's an allergic cause of the asthma. And usually a chest X-ray isn't indicated in these patients at all. Unless you're thinking it's an infective exacerbation of asthma, which mainly happens only in kids, I wouldn't do a chest X-ray. Acute management. So the management of asthma is, again, very complicated. And if you thought the management of pneumonia was bad, asthma just gets a lot worse. And COPD is even more worse. So the acute management of asthma at home, 4x4x4, which is, as mentioned, so 4 puffs, 4 breaths every 4 minutes. If that doesn't help a few times, ambulance. And then take them to hospital, of which there is a lot of therapy. But if we just look at the severe therapy, give oxygen if they need it. And you want to maintain their stats above 92%, because if we look at if you remember the HbO2 curve, after about 92, you get a very steep decline. So 92 is about the place where you don't want to let them slip by. Then you give 12 puffs of salbutamol, and then you give 8 puffs of ipratropium. And it's actually important to know these number of puffs. It sounds like a lot, but you need to know this for asthma because it's such a common condition. And if you know it now, you'll definitely know it in 4th year. So 12 puffs of salbutamol, 8 puffs of ipratropium. Salbutamol you can give multiple times. Ipratropium you just give once. After that, it has no benefit at all to therapy. And after that, then you can consider things like steroids and IV treatment. So magnesium, amniophylline. These are all very severe things. But if you remember the 12 puffs of salbutamol and 8 puffs of ipratropium and then IV medications, that's probably a very basic understanding. Then that's acute asthma. We've also got chronic asthma, which has its own 6-step management that was done by a few of the governments. And the most important step is, I guess, the pharmacology step, where you have a stepwise increase from SABA to ICS. Then you add a LABA. You don't give LABAs ever by themselves, so always give them with an ICS. And then there's all these other various medications. You can give them prednisolone or monoclonal antibodies, but these things are very expensive. So SABA, then ICS, then add LABA, and I think you're good. And also remember the asthma action plan, which even adults have, and they give them to their workplace as well. So these are all the medications. Look forward to 4th year when you have to know most of these. So occupational asthma is kind of a thing that you guys do in 3rd year in your Occ Health. Have you guys had Occ Health yet? No, so you look forward to it. It's another boring thing in 3rd year. So it's asthma that has arisen anew in someone who's starting a new job. Usually it's a reactivation of an old asthma, but it can be something completely new caused by an irritant. The classic thing is isocyanides from spray painting people. That's very classic. And there's a whole diagnosis when you're supposed to ask them to do a diary for of results 4 per day for 2 weeks on work, 2 weeks off work, and then do specific tests after that, like methacholine tests. And that's something that you probably cover in more detail, unfortunately, in your tutes. Usually in terms of management, manage it as asthma. Usually they don't need to change jobs. They can modify their job, wear a face mask or something, or wear gloves if there's an irritant caused like that. Usually they don't need to change jobs. So do you want to choose someone? Who? Does that mean someone to something? Okay, yep. doesn't mean anything to me. Yep, you want to have a go? COPD? Yeah, why? Sorry? Hyperinflated lungs, yes. And that's basically it. Also of note, the mediastinum is very vertical, very narrow, and that's due to the hyperinflation. So signs of hyperinflation would be narrowing of the mediastinum and then hemidiaphragms getting flattened. Both features that we can see here. Also, you can see more ribs than usual. And this could even be an expiration X-ray. So COPD, I think we all kind of know what it is. It's got a pretty poor prognosis if it's not managed. And there's two main forms. So chronic bronchitis versus emphysema, and they both have different definitions. So chronic bronchitis is a clinical diagnosis. So it's productive cough on most days for 3 consecutive months of 2 consecutive years, which is, it's not a very great definition, but you've got to commit it to memory. And emphysema is more of a pathological definition. So you're actually looking for destruction of the air alveoli itself. And that's something that's really important. And in terms of clinically, I guess emphysema is more characteristically associated with those pink puffers, whilst bronchitis is more associated with those blue bloaters. But realistically, people are a mixture of both. So they won't be blue and they won't be pink. They'll just look normal. But when someone's pink, think of polycythemia and think more bronchitis. And there's different types, and I'm talking about, pathology-wise, there's different types of emphysema. So we have centrilobular or centriacinar emphysema, which is the COPD type. And then we have a panacinar, which is worse because there's more destruction. And you get that in a condition called alpha-1 antitrypsin deficiency. So this is just diagrammatically. So this is really bad, the panacinar type. It's affecting all of the acini. And histologically here. So I got these histological slides from the guy who takes pathology at Easton. It's the only good thing Easton does, really, for us. Good pathology lectures. So the main risk factor is smoking. Just like lung cancer, smoking is a very big risk factor for COPD. Asthma can lead on to COPD, or a mixed syndrome, which is creatively named asthma-COPD overlap syndrome, which is increasingly becoming recognized in people who might not have smoked but are still developing chronic COPD symptoms or meet the diagnosis for chronic bronchitis. Having a low birth weight is interesting. Low birth weight predisposes to a whole lot of problems, including diabetes and a whole bunch of things. So if you're premature, you're probably going to die earlier than most of us. And alpha-1 antitrypsin deficiency as well. So the clinical features, straightforward, dyspnea, they might be pink, they might be blue. So pink, again, polycythemia, blue, cyanotic. Exacerbation of COPD is a little bit of a gray area. So it's kind of like pneumonia, but it's not really the full pneumonia. It affects the different areas of the lung. So it affects the alveoli rather than the bronchioles and the bronchi. And it's basically an acute worsening of symptoms, a worsening of cough, worsening of dyspnea, and maybe sputum production. And basically, you kind of treat it like you treat a pneumonia, and you do the same sort of investigations as you would with a pneumonia. Does anyone know what the most common cause of death in COPD is? How do people die in COPD? Anyone? Just throw out a condition. No? So they usually die with AMI. So this, again, may or may not have been asked, but a lot of people chose exacerbation of COPD because maybe they can't get to the hospital fast enough and they die of infection. But the main cause of death is AMI, and that's because of there's so many similar risk factors of AMI or atherosclerotic disease or arteriolosclerotic disease with COPD, namely smoking. Investigations, obstructive PFTs with minimal bronchodilator response, CXR we've talked about. The management plan, this is, again, a bad management plan. Like asthma, it's bad, I'm sorry, but too bad. The management plan is summarized by COPDX, which is something that people officially created. In reality, what COPDX stands for could be probably used for any condition, which is not really helpful. So C stands for confirmed diagnosis, which could work, again, for any condition. O stands for optimized function, which could, again, work for any condition. But basically what happens is we have lifestyle, pharmacology, and surgery. So when you're talking in an OSCE about how to manage a person, probably the 4 things you look at are lifestyle issues, allied health issues, so lifestyle, stop smoking, blah, blah, blah. Allied health, maybe chest physio, blah, blah, blah. Your pharmacology options, which is stepwise again, so SABA or SAMA, which is ipratropium, and then move on to a combination, then put LAMAs on board, then chuck a LABA on board, then chuck steroids on board, then chuck various combinations of what I've already mentioned on board until you have a lot of combinations. So that's something that unfortunately you have to know. And then surgery is the 4th component of your management. So you should be able to at least think of one thing for each of those, and maybe you might not get surgery in all the cases. So with surgery, they can actually take out the bullae or the lung that's not very effective in giving the person oxygen, and that'll actually improve the efficiency of the rest of the lung because the blood goes there more often. Or they can do a lung transplant, or insert various valves and all sorts of things. So the P stands for prevent deteriorations, which again is not specific to COPD at all. And vaccinations are the most important one, and COPD happens in people who are old. So pneumococcal vaccine is free vaccine, people over the age of 65 and older, and that's something that you should be recommending in your patients. Plus the influenza vaccine, because you can get viral exacerbations of COPD as well, not just bacterial. Then the main thing is oxygen use. So oxygen use only has a benefit, and oxygen use is the most beneficial therapy in terms of mortality, but it only has a benefit if you're using it for 16 hours or more a day, or more than 15 hours. So 16 hours or more a day is when it's effective. So you need to be sleeping with it, have it with you pretty much all the time, unless you're having a shower, or I don't know, you need the oxygen off for some other reason. Importantly, you can't be smoking, because if you're smoking and a bit of the flame or something gets into your oxygen mask, you're gonna explode the canister and probably kill yourself, and you'll have all these people looking for terrorists, looking at you, because it's very bad. So you just cause an explosion in your house or on the train or wherever you're smoking. People don't smoke in trains, sorry. So develop support networks. So again, very generalized. So talk to your GP. Early pal care referral if they're really struggling. And manage exacerbation. So this is how they incorporated X into it. So it's very poor. And again, that's just oxygen and making sure you pick up exacerbations early. And this is a table from an MMC lecture that's probably too much information, but for your interest. So alpha-1 antitrypsin deficiency is that pan-acinar. And basically all I'm going to say about it is that it comes with lung disease and it comes with liver disease. So they'll come jaundiced, they'll come young with jaundice and some degree of COPD, and think more alpha-1 antitrypsin will be more severe. And you treat it like COPD, but it gets worse because it's pan-acinar. Case 10, you want to choose someone? Any ideas? I mean, we've done normal and we've done obstructive, so. Restrictive lung condition, yeah, and fibrosis is probably the most common one. What makes you say fibrosis? What makes you say restrictive, sorry? So you mean FVC and FV1 are individually decreased?
Yep, and the ratio is.
Yeah, 91%, so it's normal, or it's even higher than normal. So yeah, exactly right. So they're both decreased, and the ratio is normal. And this is a very characteristic restrictive pattern on PFTs. Again, yeah, good job. So idiopathic pulmonary fibrosis is the main one that we'll talk about, and it's idiopathic. And I guess the way that fibrosis has now been described, it's been brought down from, so it's a subset of interstitial pneumonia, which is in itself a subset of diffuse parenchymal lung disease, but of all of those, you basically just need to know this one, idiopathic pulmonary fibrosis. So it typically happens in older patients. They have a chronic worsening dyspnea. They have weight loss because they just don't have the energy to eat and stuff anymore. They have clubbing, which is a very characteristic sign, and you might see clubbing on the feet as well, very characteristic, and they'll have these fine crackles. So when we're talking about crackles, we talk pneumonia, they have crackles, but pneumonia crackles are coarse crackles. With fibrosis, they're fine crackles. And you'll be able to very easily tell the difference when you hear a few chests. The PFTs will be restrictive. On CXR, you'll have this reticular nodular pattern, which you can kind of see here, bibasal here. On HRCT, which is a high resolution CT scan, you can get a ground glass appearance, you can get a honeycombing appearance. These are all stages of the same process. That's all fibrosis. And management is all immunosuppressive because we think it's an autoimmune cause and we think that might help. But also give them things like oxygen as well. And then there's all these other anti-fibrogenic drugs as well that people can try. But usually this disease progresses and it's not very well controlled. Do you want to pick someone? Yep. Can't remember if Sartak went over this or not, but. Any ideas? Anything? Sorry? Pulmonary edema, so APO, yes, I agree. Any clues as to why? Yes, definitely. Anything else? Sorry? Like here, like around here? So that's, yeah, very bat-wingy appearance. Maybe it's not very clear about the cardiophrenic angle here, but I guess there's not really much effusion in this case. Also of note, obviously the cardiac, congestive heart failure history, plus they've got a pacemaker or whatever this is here. There's also these little lines here. Does that project well? Can people see that line and this line here? No? Can you turn the light off then? Can people see that? Like, if you can't see it, just let me know. So there's a line here, just above the arrow in here. These are curly B lines. So curly B lines are fluid in the alveoli themselves, and straight lines, as I said, are abnormal. These are straight lines in the alveoli. So keep that one in mind. So acute pulmonary edema is a decompensation of heart failure. And the classic symptom that you'll get is a very acute picture, and you'll have this pink frothy sputum, which isn't really sputum, it's actually kind of like frothed up blood. But pink frothy sputum is APO until proven otherwise on an exam. Bibasal crackles, because that's where most of your changes, as you can see on this X-ray, most of them are in the basal areas. And you have an elevated JVP as well. Your investigation of choice is a chest X-ray, and then you have these classic A, B, C, D, E features on a chest X-ray. So lots of A, B, C, Ds. Sorry about that, but that's the way it is. So A is alveolar edema, which is that bat wing appearance you have here. So with the eye of faith, it looks like bat wings. So, I mean, radiologists do need to get out more, but they look like bat wings. Curly B lines, which is the B, which is those lines on the side here. So just the arrowheads will point towards these lines. So this is a really good image from NEJM that when you see at home, you can be able to see this very clearly. The C is cardiomegaly because of their cardiac problems. The D is diversion of upper lobe vessels, so they'll have the vessels will be raised. And E is an effusion, a pleural effusion. So the management is, again, something that you need to know, and the management is LMNOP. So L is Lasix or frusemide. So Lasix is the brand name for frusemide. Morphine, nitroglycerin. So these are all vasodilators. You're not giving morphine for the pain, you're giving them to vasodilate. Oxygen, high flow oxygen, 15 liters per minute. And you want an upright position, or maybe give the oxygen via CPAP or BiPAP as well. So this is something that you need to know. So we have about 10 minutes left. I didn't want to do a SARTAC and go for 6 hours. Does anyone want to go through any extra conditions as well? So these aren't on your slides, but I can post them up later. Yep. So I think I'll go over a few important ones. So acute bronchitis, very common. Everyone has it, just a chesty cough, goes away with time. Everyone's had this. Let's go over it. That's just viral infection. So bronchiectasis is something that's important. So bronchiectasis is an irreversible dilation of some of your airways. And it's irreversible because you have chronic inflammation, and this chronic inflammation leads to fibrosis of the vessels, and the fibrosis of the air vessels, or the airways are fibrosed, and that means that they can't properly dilate because the muscle is lost. So the main causes are post-infection, which is a common cause of inflammation. A lot of these people with bronchiectasis will have previous history of pneumonia or previous history of multiple COPD exacerbations. Aboriginals have it more commonly, unfortunately, like everything else pretty much. Carcinomas can cause it. Another important one is cystic fibrosis, which I can talk about in a minute. But pretty much everybody with cystic fibrosis will have bronchiectasis. So the classic signs and symptoms, and this is just I guess a histopathological classification, but the signs and symptoms important are copious amounts of sputum or cupfuls of sputum. These patients will be coughing up, they'll be able to tell you, I coughed up multiple milliliters of sputum, and they have it in a jar, and they'll proudly show it to you as, I've coughed this up. This is my baby. It might have hemoptysis. They'll get recurrent lung infections, and usually really bad ones. So we're thinking of stuff like Pseudomonas that you'll need, 4th gen cephalosporins to manage, or 3rd gen, I can't remember which one, someone look it up. And the signs and symptoms are clubbing as well. So the classic radiographical signs are tram lines on chest X-ray, and that's due to fibrosis. And I don't think it projects very well, but when you get home, you'll be able to see these parallel lines, and that's tram lining. And when you're looking at it through an axial section, we can see these signet rings. So this is a ring with, this is a stone on the ring or something. And these are, I guess, cross sections of the fibrosis, and they appear hyperdense on CT, hyperintense on CT. So in the management, again, just go through it systematically. Lifestyle, there's not much they can do. Maybe stop smoking. Then your allied health stuff, chest physio. Then your pharmacology. You want to give them vaccines, give them maybe bronchodilators if they help. Mucolytics to stop the mucus plugging and to reduce their mucus secretion so they have a better quality of life. And also you want to treat any infections as soon as possible. So a lot of people will have prophylactic antibiotics, so prophylactic doxycycline can be given as well. So cystic fibrosis, this is an autosomal recessive condition. I need to know a significant amount about it because Australia is mainly a Caucasian population. So cystic fibrosis is something that's a problem in Australia. And the rate is 1 in 2,500, and that makes sense because if the carrier rate's 1 in 25, and we drop a Punnett square, 1 in 25 times 1 in 25 times 1 in 4 is 1 over 2,500. Yep. So just know that, and that's something that you should be able to quote because it's very easy to remember. It's due to a problem in the CFTR gene, which codes for some sort of chloride channel. That becomes relevant in how we diagnose cystic fibrosis. So the main symptoms are, well, it's very, I guess, because chloride channels are everywhere, we have a lot of problems. So the main respiratory problems are, think of bronchiectasis, and that's pretty much all your respiratory problems. And they get Pseudomonas recurrent chest infections like a person with bronchiectasis would. So over 95% of these patients will have bronchiectasis. They also have exocrine pancreas deficiency, so there are problems with vitamins, there are problems with fat absorption, and so on and so forth. They can also develop diabetes fairly early on as well. Intestinal dysfunction, so the classic baby who will have cystic fibrosis won't pass their first poo. They'll have a meconium ileus. So meconium means first poo. And the similar thing happens with adults. They have a distal intestinal obstruction syndrome where it just, I guess, there's just immotility of the bowel and it just doesn't work properly. And then you have, I guess the main thing is infertility in males, but they're not sterile, they're just infertile. So remember that from your first, second year lectures. Investigations, so you diagnose CF as a baby and you do a Guthrie test, which is that heel prick test that you do maybe 3 days into their birth. And that'll give you cystic fibrosis without a doubt, but you can also do a sweat test. And a sweat test is something you do in an adult if for some reason you just wanted to look at their cystic fibrosis again. And then PFTs will have an obstructive pattern. Chest X-ray will show the changes in line with bronchiectasis, but it can also show lobar collapse, which is atelectasis, which someone will hopefully cover in a peri-op talk. And HRCT, which is the one that's used for monitoring of how bad their lungs are going, can show features consistent with bronchiectasis. It can also show this mucus plugging appearance, which is called a finger and glove appearance, which is another probably buzzword, and that's just because of the mucus buildup. It's just built up in all those large bronchi and bronchioles. Management, okay, so management of cystic fibrosis is very, individualized. Not everyone has a problem with the pancreas, not everyone has a significant problem with their lungs, although most will. So again, just go through it. Lifestyle, give genetic counseling, and then allied health, chest physio, making sure they're having a good diet, high calorie diet. So these patients can have macas every day, and that's totally fine for them. Although they also die 60 years earlier than you guys, so it's a balance. Pharmacology, bronchodilators, mucolytics, prophylactic antibiotics. There's a bunch of individualized therapies as well. Making sure that you look after the pancreas as well, so enzyme supplements, vitamin supplements, maybe manage their diabetes as well. Lung transplants, the only thing that can really prolong their life significantly, but lung transplants aren't easy to get. So, obstructive sleep apnea. I've got a few minutes left before 1.5 hours is up. So obstructive sleep apnea is another very common question on EMQ or OSCE. It's basically unexplained daytime sleepiness where they have at least 5 obstructive breathing events per hour during their sleep. So as we know, during REM sleep, everything kind of relaxes, but it's unusual for that relaxation to cause an obstruction. And when it causes an obstruction due to a variety of factors, such as obesity or acromegaly, which is that growth hormone excess, or alcoholism, where they might have a very thick neck, or something like that, like hypothyroidism, Graves' disease, and these patients can sometimes get obstructive sleep apnea. The clinical features, as you probably would have learned last year, very obvious. So they wake up gasping for breath, they have a snoring history, they're sleepy during the day, and this is really important for OC health because these patients, and in Monash exams, classically male truck drivers, because all male truck drivers are obese and they drink, so they all have those risk factors. Then they can have impaired vigilance and then crash their cars and trucks, which is obviously not ideal. And the Epworth Sleepiness Scale is there for your reference. No, don't need to know it. Obstructive sleep apnea is diagnosed with a variety of tests that all fall under the banner of polysomnography. So that includes EEG, EOG, which is on the eyes, which is like an EMG on the eyes. Because remember, we're looking at, why would we look at the eyes? For what?
To know when
Yeah, when REM sleep happens, exactly right. And then EMG, ECG, that's because other things can be causing this as well. And the main difference between obstructive sleep apnea and essential sleep apnea, which is a CNS problem, and I've written it here, is that there's no flow with effort. While in central sleep apnea, there'll be no flow and there'll also be no effort because the CNS isn't asking for an effort of respiratory drive. And you'll be able to see that very clearly when you have a look at I didn't include one, but a central sleep apnea, one of these will be very obvious because with an obstructive one, we have all this effort here, so everything's moving, and then we have no airflow. But in a central sleep apnea, all of these lines will be flat as well. So that's the difference. This is just where the leads are placed for your information. Management lifestyle, so weight loss, a lot of lifestyle things to talk about. So sleeping on their sides, avoid alcohol, don't drive. They have to have a conditional license if they're diagnosed with OSA. And then there's all these other things. You can give them sleeping pills or various splints, and then you can do that surgery that I can't really pronounce, but you can do a surgery to fix this as well. Obviously, if they have acromegaly as a cause, manage that, manage their thyroid issues, etc. That's pretty much my time up. Does anyone want to keep going, or I don't really mind? Do people have places to be? I mean, med students probably don't, but maybe you guys do. Monday night, rowdy, no? Okay, so whatever. So pulmonary, I've only got a few conditions to go. So pulmonary hypertension is another one of those matrix conditions. To be honest, I've never seen it come up on an exam. I've never seen it come up on an OSCE ever. So I guess just definitionally, it's a measure of the right atrial pressure as being more than 25 mmHg. There's different classes, and it's all fairly obvious in terms of not which class specifically, as in class 1 corresponds with this, but the causes of pulmonary hypertension. So you have narrowing of the circulation, which leads to fibrosis, and that causes pulmonary hypertension. The causes of that would be things like rheumatoid diseases that can affect blood vessels directly, or vasculitides. So SLE, RA, systemic sclerosis, or scleroderma, these are all things that can cause that. We have pulmonary hypertension due to left heart failure, so mitral problems. We have pulmonary hypertension due to lung problems, so COPD, or fibrosis, or interstitial lung disease, which is basically the same thing. Or we have pulmonary hypertension due to a problem with the vasculature because it's blocked, like a PE, which causes a very acute pulmonary edema. Very acute pulmonary hypertension. So pulmonary hypertension is the least of your worries when they have a PE. And then class 5 is just a bit of everything. Clinical features. So these are things that you need to know. The clinical signs are, there's 3 signs you need to know for pulmonary hypertension. And people have been asked in the wards for centuries these signs. So elevated JVP, left parasternal heave. So remember when you're checking for a heave, you're using, I guess, the sole of your hand here, putting it on their chest and trying to feel the heart heave against you. You probably have to, try it on a patient with obvious pulmonary hypertension. So someone with COPD will probably have this. And then a palpable P2. So you can actually, when you palpate using the tips of your fingers on the pulmonary area, you'll be able to feel the pulmonary pulse there. That's unusual. Usually you can only feel, unless you're, having a lot of coffee or something. Usually you can only feel the apical impulse. So investigations, you want to confirm the diagnosis with pressure, but usually this is kind of like a complication. So you really got to manage the actual problem of pulmonary hypertension. Pulmonary hypertension doesn't occur by itself usually. So that's basically it. And there's, I guess, specific managements as well, but probably don't need to know. So respiratory failure is the last thing on my list. And respiratory failure is kind of not very well understood by anyone really, but you have 2 main types. You have respiratory failure where the PO2 is low, but the CO2 is normal, and you have respiratory failure type 2 where the O2 is low, and because they've been compensating chronically, the CO2 is high. Okay, so type 1, you have no change in CO2. Type 2, you have a high CO2. Type 1 are acute causes, so acute, and chronic causes are type 2. And it'll kind of make sense when we go through the list of what causes it. So these are very long lists, but we can break it down very easily. So acute causes, you acutely go into high altitude. You don't, stay at Mount Everest, because you can for 20 years. Acute asthma, PE, which is acute. Acute pulmonary edema is acute, given the name is acute. Chronic causes, all your neuro causes. So MS, Parkinson's, stroke, GBS, Guillain-Barré syndrome, all of these are neuro causes, and all of those will cause type 2. And then your chronic lung conditions, which are chronic, will cause type 2. So just keep that very simple distinction in mind. Type 1 acute, type 2 chronic. And the only reason why this matters in Monash exams is there's different management for both of these. So with type 1, you use fairly low flow instruments. So you can give nasal prongs or Hudson masks, which deliver comparatively low flow oxygen. And you want to keep them at high sats because they still have a respiratory drive that's central, not peripheral respiratory drive. But with these chronic patients, because if we think of someone like those blue bloaters who chronically have, they're using this peripheral O2 or CO2 as their source of respiratory drive, you want to maintain their sats at a lower amount, because if you jump their sats up to 100, then they're going to have no respiratory drive and they'll just die on you. And that's the classic story that people want to avoid. So you give these patients BiPAP or Venturi mask. So BiPAP's the good one, Venturi mask is the old one. They'll have both on the exam, and the answer is BiPAP. And you give them 24 to 28% oxygen. So so that's a specific oxygen FiO2 that you're giving them, rather than with a Hudson and O2 prongs, you're just giving them 100% oxygen. So that's the difference. And then I have a bunch of questions that you can all go through at home. And there's more than enough to keep you busy for at least an hour. Any questions? No? All right, feel free to message me on Facebook or stalk me at Epworth, because I'm always there. Yeah, good luck with your exams. I'm sure you'll be fine. Make sure you beat my brother.
Thank you to Rohit Sharma for that amazing presentation. And to all of you at home, good luck.